Hi, everybody. Good afternoon. I hope you're having the most beautiful day, and I hope you've been able to enjoy some of the content that's been happening uh, previously as well as today. But thank you for joining our session today. So I'm Kate Ketch. I am the director of the Department of Evaluation and Research Services at Fraser Health. Yeah, I just have to say that I'm just like so pleased with this provincial showcase, and I've just been so impressed so far, and I'm feeling inspired and educated and stimulated and transformed, all those words that that are attached to 5 days in May. Before I start, I do wholeheartedly want to recognize, and with genuine appreciation, that I work, live, love, laugh, and play on the beautiful, ancestral, traditional, and unceded territory of the Squamish, Musqueam, and Tsleil-Waututh First Nations. I'm looking outside. It's a beautiful day. I enjoy the land. I've been in BC for 15 years, and I just can't get enough. It just makes my heart warm and full every single day. Most people hear me a whole lot in these sort of events that we do, and we felt like that was maybe boring. So we thought to do the official opening for our session on Indigenous health, we should have a very spectacular human do a bit of an opening for us. So Michelle Jane, you are a beautiful man, and you are the Director of Strategic Initiatives for Indigenous Health at Fraser Health, and I'm passing it off to you to start off our session.
Thanks, Kate. I really appreciate that, and a really great way to start this session. I'm deeply honored to be the one to come here and speak to all of you and just do the little bit of a welcome to this really incredible session on Indigenous health as part of the 5 days in May, the BC Provincial Research Showcase. You know, Fraser Health has been for many years now actively working with Indigenous communities and governments and organizations within the region to ensure the highest attainable standard of care and wellness for First Nations, Métis, and Inuit people who access services in the region. 2 years ago, it was made abundantly clear that our mission statement needed to grow a little bit, and that mission statement needed to include Fraser Health in collaboration with Indigenous partners working to address Indigenous specific racism in the healthcare system. In my role as director, I've seen incredible development and growth from allies within the organization, communities who are willing to partner with us day in and day out to achieve this goal. As you'll soon learn, the work that is happening within the world of research and evaluation is absolutely critical to us achieving that goal and to ensuring that Indigenous peoples experience the very highest standard of care, the very best experiences as patients, as families. One area that I just would love to highlight here is the relationship that we have with the Department of Research and Evaluation Services. That relationship has really blossomed into an incredible collaboration. And one of the areas of that collaboration has been the introduction of the inaugural research and evaluation specialist role for Indigenous cultural safety. Really an incredible role that is kind of exemplifies the desire and necessity to bolster our ability to partner with communities to support good research, community-driven research. And so really excited to see a couple of really critical projects being highlighted today. These are both wonderful projects, incredible endeavors, and I'm really pumped to see what they have in store for us as part of their presentation. So with that being said, maybe I'll turn it back over to Kate to introduce us to our first speaker.
Sure. Thank you so much, Michelle. And way to use the term pumped. Like, that's a good way to start the show for sure. So sort of speaking of that, research and evaluation specialist in Indigenous cultural safety, our first presentation is by said individual and partnered with, her co-investigator on the project. So I think I have that right. Margot, you're up first, right? Margot and Debbie? Yes.
I think it's Jen and I, yeah.
Perfect. So sorry, Jenny, sorry, why did I say I switched it. There's too many good people that are talking today. Okay, so with that, I'm thinking I'll just pass it off to you. I always get like, should I introduce them officially, or sometimes they want to introduce themselves, but so I say you guys just start sharing that screen and tell us about the good work that you've been up to.
Sounds great. I will just share my screen. Everyone can see? Thumbs up. Okay, great. Yeah, hi everyone. We'll be presenting today on developing Fraser Health protocols for respectful research and evaluation involving Indigenous peoples. Why, how, and what's next? And so I just want to, oh, sorry, where's the next slide? Sorry. I might have to reshare. It's not working. One sec. Try again. Great. I'm going to invite Dr. Jenny Morgan to introduce herself first.
Sure, thank you. It's nice to see all of you. My name is Jenny Morgan, and I'm from the Gitxsan First Nation. I am joining you today from the unceded and traditional homelands of the Songhees First Nation. In my day-to-day work, I am an assistant teaching professor at the UVic School of Social Work. And previous to this, I was with PHSA for a number of years as the director for Indigenous Health at the BC Women's and Children's Hospitals. And so with that, I partnered with Margot today to present our presentation today. Thank you.
Thank you, Jenny. Yes, I'm Margot. I'm an uninvited white settler person with European ancestry. I am the research and evaluation specialist with the Indigenous Cultural Safety Team here at Fraser Health. I'm grateful to be calling in today from the unceded, traditional, and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations, colonially known now as East Vancouver. I'd also like to acknowledge the lands where my desk space is at Central City, where I think many of you must be calling in from, which is on the traditional and ancestral lands of the Semiahmoo, Katzie, Coquitlam, Kwantlen, Kakite, and Tsawwassen First Nations. I respectfully acknowledge their stewardship of the land since time immemorial. I'd also like to acknowledge that the space is on the homelands of 5 Métis chartered communities. And I will pass it back. Oh no, sorry, I'm doing the next slide as well. So in this presentation, we want to be really clear that research and evaluation have been used as tools of colonial violence that have negatively impacted Indigenous peoples. And so we're going to provide a background on that and why Indigenous peoples, many Indigenous peoples, consider research and evaluation to be problematic and harmful. And so why Fraser Health needs its own research and evaluation protocols to help mitigate that. And in the meantime, to introduce 6 R's that will help researchers and evaluators do better. And we also will be giving everyone an update on the Fraser Health protocols that we're developing and sort of a bit of a snapshot on what that might look like in the future. So I will pass it back to you, Jenny.
Thank you. So when we're thinking about the reality of research and evaluation and the impact on Indigenous peoples, what we're talking about is we're really looking at research and evaluation as tools to leverage colonization and how research can support colonial systems and institutions, erase Indigenous peoples' experiences, and diminish Indigenous knowledges. And these inappropriate methods and practices continue to cause significant harms to Indigenous peoples. And researchers and evaluators can avoid contributing to these patterns by continual reflexivity work, which is reflecting on how your prior research experience, assumptions, biases, beliefs will influence the research process, and by listening, learning, and following Indigenous direction.
As you know, Jenny's been saying, Indigenous peoples have been telling us for decades that Western approaches to research and evaluation contribute to colonial violence. And we cannot say that we have not heard that message before. This is not new. And so it's high time that we do something about it. in a meaningful way. And so the fact that Fraser Health still doesn't have its own framework to decolonize research is a symbol of systemic racism, systemic violence. And so there's a growing number of protocols and policies that guide researchers and evaluators to do better. And some of these are pictured here. These are a signal that there's growing acknowledgement of their necessity and a willingness to disrupt white supremacy within research and evaluation. I'd like to point out that the photo in the top left is Dr. Morgan's recent project called Pathways for Developing Patient-Oriented Outcomes and Experience Measures for Indigenous Peoples. It's a project that was carried out with UBC and BC Women's Hospital Indigenous Health Program. We can always supply links to these documents, and I think that you'll find them very useful as well. And I'll pass it back to you, Jenny.
Thank you. So thinking again back at the historical pieces around research and evaluation, we can really frame that as trauma and what that looks like in the experience of Indigenous peoples. And we can go back many decades of this harm being done. There's several examples out there, but we just listed a few here. You can look at the 1930s and 40s of vaccine experiments being done with infants in Saskatchewan. In the 40s and 50s, there were several large studies carried out in Manitoba with First Nations communities and of course in residential schools without consent, contributing to the appalling death rates of Indigenous peoples and children. And then in the 1980s, there's a UBC researcher, Ward, who took blood samples of the Nuchalnath peoples in one study, but left the community and used those samples for other research without the consent of the community. So this is really just giving you a short snapshot of the harms that and the legacy that research has left in Indigenous communities, and what we really want researchers to be aware of when looking at doing research with Indigenous peoples, that history and the well-founded distrust that exists with Indigenous peoples.
Yeah. So it's very clear that research and evaluation have historically and presently support colonial systems and structures. And so how can we as researchers and evaluators do things differently and be better? So right now, with the support of the Fraser Center Support Unit and DERS, we are carrying out engagement with Indigenous communities and thought leaders to do just that, and that takes time. So in the meantime, we're hoping to introduce the 6 R's as an approach that you can start today to mitigate or arrest any potential harms. And those are respect, relevant, reciprocity, responsibility, reflexivity, and relationships.
So we'll start with respect, which is recognize and respect Indigenous cultural norms and values. And we're going to provide examples of each of these R's and examples of what they might look like if they're not implemented. And these are, a lot of them are real life and current examples that we've experienced. So examples of respect are working to understand and practice community protocols, seeking out and holding up Indigenous perspectives, taking extra steps to ensure elders and knowledge keepers are honored, and asking for help if unsure about protocols. Examples of disrespect are ignoring or diminishing protocols, so inappropriate land acknowledgement or making light of or making fun of land acknowledgements, disregarding Indigenous expertise and perspectives, and failing to put research or evaluation findings into context.
And the next R is relevance, or ensuring research and evaluation are relevant to Indigenous peoples that the work is meant to serve, meaning that the work acknowledges and meaningfully integrates Indigenous knowledges and cultures. So this teaching really underscores the importance of humility, really taking a back seat, and as Jenny said in the previous, R is upholding Indigenous knowledges and direction. This requires us to be sincere in our efforts to engage Indigenous communities early in the conception and design of our projects, to ensure that they're responsive to community needs and to recognize the diversity of cultures, languages, and worldviews of Indigenous peoples. On the flip side, or lacking in relevance, I'd like to highlight the very last point especially. Jenny and I had a long conversation about this one, that many Indigenous peoples and communities are being asked to collaborate or to partner on projects, which is great. However, if you reach out to a community and they say no, for any reason, please take that answer at face value. The project may not be relevant to the community, or perhaps they're simply too busy to take part at this time. Back to you, Jenny.
Sure, the next one is reciprocity. And this is ensuring research and evaluation is mutually beneficial to the researcher and the participants. And so some examples are developing a mutual meaning for the work being done, continuous knowledge translation and exchange, shared learning, listening to Indigenous communities, and answering how does the research give back to Indigenous peoples? So being able to answer that question when thinking about a research project with Indigenous peoples. And examples of work for oneself where reciprocity is not in place is extracting information from communities for oneself or institutional advancement, no report back to the community where the data came from, ignoring community goals, failing to bring results back to the community once the project is done, or tokenizing throughout the process of Indigenous peoples in the research project itself.
And now we're at responsibility, or taking responsibility for participant safety. And this might sound like general advice that you learned a long time ago for research and evaluation involving humans. But in the context of Indigenous health, you must also take responsibility for decolonizing the project. So examples include budgeting for elders and Indigenous patient partners, providing honoraria and covering other expenses that ensure meaningful partnerships and collaborations. It might also look like investing in anti-racism training for yourself and for your team. Examples of lacking in responsibility were hopefully have been made very clear in our previous slides, but this could also look like failing to adhere or follow protocols, failing to acknowledge and address your role in colonialism, or failing to meaningfully partner with Indigenous peoples.
And the next slide is on reflexivity. So locating yourself, recognizing power imbalances and how they impact research and evaluation. So examples of this are when you're practicing reflexivity, it's exploring your own biases, assumptions, values, and privilege, seeking out new learnings, levels of understanding and humility, engaging in anti-racism training and action, and ensuring Indigenous people's perspectives and knowledges are privileged. Examples of lacking reflexivity are talking over and interrupting, failing to recognize colonial barriers, being rigid and controlling the process, and avoiding action out of fear of making mistakes.
So you might notice that there's starting to be some intersections and overlaps between the R's. And we put relationships last because it really emphasizes the overlap and the interconnectedness between all of them, and the critical importance of tending to relationships with Indigenous research partners. And good relationships are built upon the foundations of those previous R's. So hopefully by now, relationships are evident as being absolutely integral to a research process. And I'd like to point out a couple of examples, including making space for all voices at the table when you're engaging, listening very carefully when people are telling stories or sharing teachings that are offered by project partners, resisting the urge to rubber stamp your project as having engaged with Indigenous peoples by tokenizing an Indigenous project partner. And we're at the end, we're of course open to talking more, answering questions about any of these. So I'm now going to switch gears here to talk about Fraser Health's protocols for research and evaluation involving Indigenous peoples. So I hope we've made it very clear the reasons why we started this project, which was back in November of 2021. And it was a collaboration between Indigenous Cultural Safety and the Fraser Center Support Unit. At the outset, we invited a number of people to take part in a steering committee to guide the project, and we hired a part-time research assistant, Rebecca, who I hope is on the line, and has been amazing in putting all the work together for us. So our idea was to borrow from existing research and evaluation policies, principles, and practices, because there are many incredible Indigenous thought leaders and experts in health and experts in research and evaluation that have done amazing work, including Dr. Morgan, who's on the call today, to shape, doing this good work in a good way. And so our idea was to borrow their wise and best practices, and then to align them with Fraser Salish worldviews and teachings. So our approach to the project was first to carry out an environmental scan of all the research and evaluation protocols that we could find globally. And we found many results and distilled them down to 9 protocols. And then we hosted an information sharing circle with Indigenous students, cultural advisors, leads within the Aboriginal Health Department. And this circle was facilitated by our cultural advisor, Carol Peters. And we were really sure to make sure that we had both Métis and First Nations representation in that circle. And our next steps, so that was an amazing afternoon. It was all afternoon, and we managed to work with Central City to deactivate the fire alarms so we could have some smudge ceremony. And it was a really powerful afternoon where a lot of wisdom was shared. Our next steps are to host additional sharing circles with Indigenous communities and patient partners within the Fraser Salish region, and then to collate all of that information into a protocols document that will be a living and breathing document that can be used by Fraser Health researchers and evaluators. So thank you all so much. I just want to say, as we learn and grow in relationship with one another, that I please invite anyone to discuss or ask questions in the chat or here about the words that we've said. And if you have any questions, hopefully we can answer them, and to continue to unlearn and learn together. And there's some references here. And of course, there's many, many more we could share. Thank you all so much.
Excuse me. Thank you so much, Margot. And excuse me, Jenny, sorry. Looks like there's some questions in the chat, or a question. So Josephine has said, thank you so much for this info. Wondering what is your observation about application to OCAP in research?
Jenny, did you want to answer that one, or what are your thoughts on it?
Sure. Yeah, OCAP, it's definitely for those, it's around ownership, control, access, and possession of data. I think that it's definitely a part of informing the work that we do. And I think that's a much broader piece as well around relationships with the local First Nations and data governance. And it's also like a structural piece around how do we implement OCAP and think about the systemic and structural barriers to that. So yeah, it's definitely a part of my own analysis of the work that I do. I think it will be a part of the work that Fraser Health is carrying forward when engaging with community and patient partners and others around that piece. I think it's definitely going to, it'll be work to come in the work that Fraser Health is doing. I don't know if Margaret has anything else to add.
Yeah, I echo what you're saying, Jenny. And I think that, you know, like, yeah, OCAP is such a powerful framework. And I will just say that, like, I think that we would need to sort of think things through. It is a very First Nation centric approach. So like learning how to adapt the framework and the principles and the and overcome the barriers so that it's inclusive of, all Indigenous peoples, I think would be really, really important. And data governance is such a huge piece of of decolonizing research and evaluation processes. So yeah, these are all really good questions that we're definitely exploring.
Thank you. I see Mike has his hand up.
Yes, I do. Thanks very much for that presentation, actually. And my questions are definitely around OCAP in terms of the ownership, control, access, and possession of data, how that's going to be implemented, because that's really important in terms of the Tri-Council, especially Chapter 9 of the Tri-Council ethical protocols. The next thing that I really would like to, now, how is that going to work like with public health? Because public health, I listened to a presentation yesterday by one of the Indigenous doctors, and he was saying that with public health, they're having some difficulty because their staff in terms of Indigenous staffing is very, very poor. And in terms of getting information is very difficult. So most likely that's an agency that OCAP is going to be sort of a challenge to implement. And the next question is that, you talk about Western approaches to research, and that's going to be a problem because I can see, for instance, when we talk about designs, we talk about randomized controlled trials, and those in terms of the hierarchy becomes what they call the gold standard. Lived experience and qualitative experiences is sort of thrown out, but qualitative is coming to a strong sort of intervention at the moment. How is that going to work in terms of having those old designs, quantitative designs, qualitative designs? How are those going to work in terms of new Indigenous sort of experiences? The next thing is that how many of these have been, in terms of the Truth and Reconciliation document, how many research protocols problems so far have been sort of acquired through the Truth and Reconciliation, the call to action? You remember we have 94 of those. How many of those have really been acquired and settled? Do we know how many of those in terms of research?
That's a really great question, Mike. I think that, as far as addressing the calls to action around research, I think that, there's always so much more work to be done. I think that really it's been a bit of a slow go in that department. But one question you had, and I hope I'm keeping track of, because there are several, and maybe we should email each other about them. But I was just thinking about your question around methodologies. And Jenny, I know you could speak to this as well, is that there are so many brilliant Indigenous scholars who have written textbooks and books and articles on research methods that skillfully integrate qualitative and quantitative information, epidemiology, biostatistics, conversational methods, mixed methods, and so that there's no need to recreate the wheel when it comes to methods, because all of this hard work is being done now. And so, if I can help anyone or point people in the direction of some amazing methodologists, please let me know. Jenny, did you have any comments for Mike's question?
Sure. Yeah, just thinking about each of your questions, the piece around OCAP, I think what I would encourage researchers to do is to really think about OCAP in, oftentimes it'll be a project specific time of reflection. What does OCAP look like in the work that you're doing? Because there's many barriers to implementing OCAP, even in the research work that I've done. So it can also be just outlining the limitations, the systemic and structural limitations that are preventing you from implementing OCAP, because it is a very large issue that's discussed. And oftentimes we might be in positions where we can't change the system, but we can actually raise awareness about it, about the challenges that exist. And I'm thinking about methodologies, the same what Margot was saying. There's ample Indigenous scholars that have been writing about decolonizing methodologies. Linda Smith was one of the first back in the 90s that really raised that. How do we decolonize methodologies? Because like what you said, the Western approaches are very colonial approaches because they're not taking into account other worldviews and dismissing Indigenous worldviews in the work that how it's conducted. So yeah, there's definitely ways to begin that journey of decolonizing. And then with the TRC question, I think that's a very valid, important question. I would say that's a question that we should all be asking the government, because they made a commitment to truth and reconciliation and calls to action. When you look at even the In Plain Sight report that came out a couple of years ago, Marielle Interpellefon said very little to nothing has been done since that report came out. So it's definitely a standard theme that exists when reports come out, that little to no action is done. So that's something that we can all think about, like how can we continue to advocate and be a voice and demand change with the governments who make these commitments.
Well, thanks, Jenny and Margot. Just one problem. The thing, I teach research at Douglas College. And the problem is that with teaching these hierarchy, the textbook that they give me to teach from is all Western sort of methodology and design. So I have to be working strategically around RCTs, randomized controlled trials, and all of these sort of quantitative designs to show that, well, in terms of the hierarchy, that really is not the gold standard, really. We have to look at other things, or the different, blending the two, quantitative and qualitative, but changing those designs to suit the epistemology of Indigenous knowledge research. So those are just a bit of my concerns.
Yeah, sorry, I'll just respond. I teach at UVic at the School of Social Work and teach research methodologies as well. And that's definitely a constant challenge. We do try to always have a decolonial and equity lens in the design of our syllabus. So oftentimes other institutions reach out to us. We're more than happy to share if that can help, just share how we approach it and to share that knowledge and approach in teaching.
Good. Would like to collaborate with you on that.
Sure.
That's exactly what I was going to say. I had this feeling Jenny was going to say she had some resources that she could share with you, Mike. And thank you for always your passionate questions. I'm recognizing time, but I see that Diane has patiently had her hand up. So I want to sneak in one more question before we move on to our next presentation.
Yeah, thanks so much, Kate. Diane Sawchuk calling in from the traditional Coast Salish here in Victoria. I just want to say I've had the privilege of leading and am leading 2 grants, one from Shirk and one from Michael Smith on Indigenous co-leading, always with an Indigenous co-lead. And for all of the applications that go in, they're done in collaboration with FNHA. And each grant in the FNHA review by their Executive Research Committee compares and, or I should say maybe critiques the protocol application against their 7 directives, that they are community driven, increases First Nation decision-making and control, improves their services, fosters meaningful collaboration and partnership, develops human and economic capacity, is without prejudice to First Nations interests, and it functions at a high operational standard. And so I just wanted to outline that because I think some of the challenges that are being discussed here, specifically, Mike, that regardless of the study design, the entire protocol has to meet these directives. And so this really is the gold standard for FNHA before they will sign off a letter of consent and be involved. And if they don't, then that's not a study we move forward with. We absolutely want to work in concert with and in partnership with FNHA. So I just wanted to add that. Thank you.
Thank you. Oh, not on mute. Good. Thank you, Diane, for sharing that. And a great example that obviously that, yes, there's a lot of work and good work that's gone into this and doing better, but there's a long way to come or to go still. I want to thank Margot and Jenny for sharing, and I want to already invite you back next year to tell us how these protocols have shaped up and hopefully fully successfully implemented or started to be implemented within Fraser Health. But thank you so much for that. So moving on to our next talk, we have Jade and Debbie going to speak to us. I think, Camille, you're going to do the slides. Is that right? Okay, so so Jade and Debbie, you have the floor.
Great. I just want to make sure everyone can hear me. Lovely. Okay, I'll try and keep this as condensed as possible because I know we don't have a ton of time. So I just wanted to start with say good afternoon and welcome to our collaborative presentation on Carefit in communities today for the 5 days in May. And I just wanted to thank you for having us and welcoming us into your day to share with you. Next slide.
Sorry, I just want to make sure that we're seeing the correct slides. Is it just the main slide, or are you able to see the notes too?
We can see the notes still, Camille.
Okay, let me switch that up.
There you go. That looks good. You can go to the next slide if you'd like. So I wanted to begin our presentation with recognizing that myself, I am calling in today from the unceded and traditional lands of the Stalo people, particularly the Achalites, Chiam, Squaw, Shwe, Squayala, Chiacton, Quaiquaipliit, Suwali, Skokale, Yaquiquius First Nations. I'm also honored and thankful to work and live and play on these lands. A quick introduction of myself. So my name is Jade Weirks. I work with Fraser Health Aboriginal Health as the Indigenous Elders Program Coordinator. I'll go a little bit more into what that looks like at the end of the presentation, and I will pass it on to Debbie to introduce herself.
Next slide, please. Thank you, Jade. Welcome, everybody. I'm delighted to be here. My name is Debbie Chong. I'm the provincial coordinator for the Carefit Program and the lead trainer for the Carefit Program, and I'm representing BC Women's Hospital and Health Center. It is with gratitude and deep respect that I acknowledge the generosity of the peoples of the Tsawwassen First Nation to allow me the privilege of living and playing and working on their land in Ladner, which is part of their beautiful traditional ancestral and unceded territories. And I'm grateful for the privilege of being here. It's a wonderful day out there today. So apologize for keeping you inside. This presentation is going to touch a little bit on the effects of aging on our seniors, especially those in care, and some strategies that we can work on to improve their quality of life. Next slide, please. So what happens physically as we get older? I'm inviting you, our audience, to participate with me, if you don't mind, as I demonstrate an example of the effects of a potential postural change as we get older. So can you kind of push your chair away from your desk a little bit, give yourself some room just to move your arms. I'm not going to ask you to stand up and run around the place at all, but if you could sit tall with your very, very best posture. And just, I'm going to show you, take your arms out to the side. And my room is very small, so I don't have a lot of space to work with. Arms out to the side and lift them up as high as you can. And then bring them down. Now take your arms in front of you and then lift those up as high as you can. And it should feel really, really good, just to stretch out for this afternoon. Okay, now I would like you to assume the posture, the stooped, curved posture that we typically see in some older adults. So you're gonna kind of curl up just a little bit, you have that stoop posture. Now do these activities again. Take your arms out to the side, keep your eye on the screen. Take your arms out to the side, and it'll feel a little bit differently, doesn't it? Okay, now keep that stooped posture. Take your arms in front of you and kind of lift them up as high as you can, lift them up. And I see that a few of you are kind of stuck. Okay, bring your arms down. Now take your arms up again with your best posture. Your arms went right up in front of you, they went way up. So what happened with your stooped curved posture was a slight postural change that affected considerably your mobility in your shoulders. Next slide, please. Can you imagine trying to put a sweater over your head with that posture? Would it be a challenge? What do we need to actually maintain and be independent? So a simple postural change could affect something like your self-care, combing your hair, getting dressed. What about something like the loss of your flexibility and your strength? How would you get up off the floor if you tripped? Next slide, please. So what I'm going to do in the next few minutes, I'm going to give you a synopsis about Carefit, and then I'm going to pass it on to Jade afterwards, and she will share information about Carefit in the Indigenous communities and about the CHIR grant, mobilization grant that she has received for this program. Next slide, please. We are facing some significant challenges, and according to the Public Health Agency of Canada, falls are a leading cause of injury and hospitalization in Canadian seniors. And we also know that falls are 3 times more likely to occur in frail seniors who are living in a care facility compared to seniors in the community. The Carefred program was developed partly in response to this increased risk of falls, and also due to the limited availability of trained professionals like our physiotherapists and our recreation therapists, limited availability in seniors living and in assisted living, long-term care, and those involved in day programs. Next slide, please. What we do know is that stats from Public Health Agency of Canada show that there's an increased rate of fall-related hospitalization among men and women, with women, though, having an increased rate of falls compared to men. But I also want to note that this data is a bit limited and it doesn't reflect the diversity of people who are experiencing falls. We are unaware at this time of any data about Indigenous peoples and falls in Canada. Carefit was an adaptation of the Osteofit program, which is basically women-centered, based on evidence that women have an increased risk for osteoporosis. And our program has evolved, which is really, really cool, to reflect a bit of diversity. And we recognize falls affect seniors of all abilities and all backgrounds. Next slide, please. The Carefit program is a physical activity program. It's a fall prevention program. It was developed out of a partnership in 2009 with Fraser Health and BC Women's. And it is a program that includes and targets movements that are very, very simple. We aim to improve mobility, posture, balance, functional strength, agility, and coordination. And it is provided to the seniors in long-term care, assisted living, and those attending adult day programs across the province of British Columbia. Primarily, though, a lot of the programs that we do have running right now are in the region of Fraser Health. Carefit sessions are run by the staff, and the staff are employed in these facilities. They have received a training program that is run by BC Women's and Fraser Health. To assess the efficacy of this program, we do include pre and post measures of functional mobility and gait speed. Thank you, next slide. The significance of the program is that based on current research, published research, and some as recently as a few weeks ago, we do know that Carefit is beneficial for older adults living in assisted living. And it is important, more specifically, that programs need to be progressive. And they have to target mobility of the joints in every direction. We need to be able to support the trunk. We need to be able to do strength, including upper body strength for all the activities of daily living. We need to be able to turn and change direction when we're walking. We need dynamic balance and stability And we need reaction, which is often overlooked in many programs that do deliver fall prevention strategies. All of these elements and more are actually integrated into the Carefit program. Next slide, please. What is important is, let's take a look at some of this data that we have collected so far. And this is from a study that was done in, or data that we collected from Carefit classes in 2015, 2016, and it involved 7 assisted living sites. 67 participants were involved in it, and we measured walking gait speed, so the 4-meter walk, we did the timed up and go, and we did the 5 times sit to stand. What we found, if you can see from the graph, is that there was a 76% improvement or maintenance of gait speed with the 4-meter walk. We also saw 72% improvement or maintenance of mobility and balance in the timed up and go, and 85% of the participants improved or maintained their functional lower extremity strength in the 5 times sit to stand. This is important. What I want to point out to you is that improved or same, knowing that seniors in general, as with advancing age, are likely to decline in function. So if they stay the same or improved, that's actually a very, very positive outcome. We also have seniors who declined in ability, and it's important to note that these declines could have been due to experience acute health challenges over the duration of the course, and also that some of them with advancing age and chronic diseases may have also declined a little bit with their declining health. Slide, please. Key points, this is some feedback we received from the seniors who participated in the program, is that with their improved mobility, things that they found were that they're easier to get around. They could use their cane instead of their walker. So that was a great progression for them. They also experienced less pain. Their knees felt better, which enabled them to walk more, which also gave them increased confidence. And with that increased confidence, they had a less fear of falling. And we know that fear of falling is actually one of the factors of increased risk for falls. But if you look in the middle of that chart, you'll see something else that they told us, and that the program was enjoyable. Key points to note are that adherence to any program is critical. If you don't enjoy a program, you're not going to participate in it. And we want them to participate. So the Carefit program is actually fun, very, very engaging, and it encourages and promotes social interaction. Next slide, please. The Carefit Facilitator Training Program includes 2 days of in-person classroom learning. There are opportunities for mentorship. We try to do in-person mentorship, but a lot of the times we're now having to do online mentorship. We asked the facilitators to run 10-week classes, 10 to 12 weeks, using and also doing the pre and post test. At the beginning of the session, they start their pre-test. At the end of the session, they do post-test. They need, after their practicum, to do a competency evaluation, at which point they will receive their certification in Carefit. And that certification is valid for 2 years. They need to attend a refresher training program in order to maintain that certification. Things that we cover in the training course include just very basic human anatomy, the role of physical activity. We talk about the principles of training that we apply in Carefit. We help them to develop program designs, and they get a lot of opportunities to practice. Next slide, please. Some of this feedback we got from our facilitators included things like they have a better understanding of the challenges. So they were seeing an improved skill, improved knowledge, learning what is good to do and what is not so good to do. Explanations they found were helpful, and that they could connect with other professionals working in their capacity. I'm going to turn it over now to Jade, and Jade is going to tell you a little bit about the Carefit within those Indigenous communities that she's working with, and she'll take it from there. Thank you.
You're on mute, Jade.
Oh, sorry. Thanks, Debbie. Camille, you can go to the next slide and I'll continue on. I'll just be aware of time. We're ending at 3, Camille. Okay, I'll try and go really quickly. So I just wanted to switch over to how Carefit within the Indigenous communities we work with has been used and how we plan to further this initiative. As I mentioned at the beginning of the presentation, I'm the coordinator for the Indigenous Elders Program in the Fraser Valley East. The Indigenous Elders Program began in the spring of 2021 and is a collaboration between Fraser Health and 4 community partners in the Fraser Valley East. These communities are from Chilliwack to Boothroyd. This program's goal is to support elders in their wellness through programs or support in order to decrease frailty and keep elders at home in their community longer and out of acute and long-term care. So through this program, we have been using Carefit with elders as the recreation therapist with our team is trained in Carefit and has used Carefit for many years in her work with other day programs within Fraser Health. So with the start of this program, Carefit was introduced to the communities through this collaborative, as movement and fall prevention have been a huge request of the communities and the elders we have been seeing. So we are a year into the Indigenous Elders Program, and the elders and staff have been enjoying Carefit, are seeing the benefits, and as Debbie said, are having so much fun. So some of the feedback we've gotten from the elders and the staff are comments including, I really noticed the improvements at home and I feel a lot stronger than before I started. One of the staff said the elders always look forward to coming every week. And another comment I've heard is, I've been trying some of these exercises and movements at home whenever I remember and able to. These comments really attest to the amazing program Debbie has built and how engaging and fun it is for the elders. Next slide, please. I just wanted to share a photo of the Fraser Health Recreation Therapist, Stephanie, with the Indigenous Elders Program leading Carefit at one of our partner communities at Stehalis. I think this picture really encompasses the beauty of Carefit. Carefit is meant to be fun, engaging, beneficial, and bring a sense of community and wellness to those who participate. And I feel this photo really embodies that, so I wanted to share it with you. Next slide. So as we've moved forward with Carefit, an idea to have more individuals trained in Carefit rather than just us as Fraser Health staff was proposed. This would help to create sustainability, longevity, consistency, and more frequent programs within the communities. In order for this training to be successful, it was proposed that the training be slightly adapted from its current form. Some of these adaptations are to include, I'll just quickly go through them. So the training to be in 3 days, including the relevant anatomy. Right now it's kind of a separate course. To adapt the current toolkit to be more fluid, user-friendly with images and movements and include cultural graphics. And to host the training at a community site, include meals for fellowship and a safe space for participants during the training, and to have an opening prayer by an elder or community member to start off the training in a good way. This is a photo of Stephanie again with one of the elders at Boston Bar using Carefit. So you can use it one-on-one as well. So with the amazing uptake and interest of Carefit, next slide, sorry, I should say that before. I was on the hunt to find funding to make this initiative happen. The funding was important to have the training be barrier-free, so in terms of cost and location, so that Debbie can come closer to us in the East, adapted in an appropriate way to be a safe and welcoming space for the participants. So during my hunt, I was shared the Canadian Institute of Health Research Knowledge Mobilization Grant through the research team at Fraser Health. This grant is a knowledge mobilization award that recognizes and supports up to 4 exceptional groups working in nonprofit and voluntary sectors in their knowledge mobilization efforts in the area of aging. The CIHR Institute of Aging further states that they are dedicated to fostering excellence and innovation in the area of aging research and to catalyzing the application of research findings to policies, practices, and programs that provide real-world benefits. So the grant stated, if approved, would provide $10,000 within these initiatives and framework of aging programs. There was also a specialized pool for this application. So this application pool is to encourage applications from organizations focusing on older adults from groups that are historically underrepresented, which includes Indigenous peoples. So after reading through all the requirements and initiatives, I thought this was a great fit. I'll just briefly go over this. So with this, the proposal of Carefit in Communities was written and submitted. The grant application included questions such as a proposal, a target audience, timeline, budget, proposed initiatives, the outcomes, long-term goals of the initiative, how the initiative will use knowledge mobilization to enhance the impact of available knowledge, and how the proposal lines up with certain strategic directions. I'll probably skip the rest going into it just for the sake of time, so I'll go to the next slide, please. So plans moving forward with the grant. So after our application submission, we were successful in receiving this grant through the Canadian Health or the CIHR. And we look forward to running Carefit in Communities initiatives. So it is booked for September 2022 at a community in Stala, which is in Chilliwack, BC. So part of this grant will be going towards paying for the training, so there is no cost. We are also working to create a culturally safe environment for this training. This includes the opening prayer, where there'll be an honorarium provided, a safe open space for learning, so an honorarium for using that space, a light breakfast and lunch for each of the training days. We will also be supporting a local Indigenous owned catering company for this. There is also work on adapting the toolkit to be more user-friendly, easily understandable, and with culturally relevant images and design. So we've been working with Debbie and her team on this, and with our community partners who are familiar with the Carefit program. We'll also include kind of a Carefit bag with all the necessary equipment for everyone to take home to their communities. Next slide. So for evaluation of this, we're still in that process. There were no major evaluation criteria for the grant, but they will look for something. So since Carefit itself is already evidence-based, the evaluation is specifically going to be looking at the uptake and the content of this training itself. So this could include how many people were able to take the training, feedback on how the training was in terms of content and relevancy for the participants in their communities, feedback on the toolkit and its use within the training. We also want to try and look at how the training is being used after the sessions are completed. So some examples could include, have you been using Carefit in your role? How many groups have you been able to facilitate? What are your feedbacks on the Carefit toolkit as a refresher or a reference? Are the elders enjoying it and finding it useful? Are you feeling supported if you have questions? We really want to be sure we allow those who have taken the training to have their voice heard on how this training is for their specific community and their elders, and be able to support them in navigating their role and any adaptations that are needed. And next slide is just a thank you for having myself and Debbie and listening to Carefit and how we look to take this further with our Indigenous community partners. We look forward to continue to collaborate on this initiative this fall. Thank you.
Thank you, Jade and Debbie, so much. Any questions from the audience?
Just to thank Debbie for that little bit of exercise.
Absolutely.
I can move around. I can move around now.
Oh, great. It is important at this time of the afternoon to at least get a little bit of movement in. I'm glad you participated. Thank you.
Thank you.
Yes, that was excellently timed. A good stretch. Thank you so much, Debbie and Jade. I know I said this for the last presentation, but I look forward to you coming next time and telling us all the great success that you had with implementing this and learning from the training. And I love knowledge mobilization efforts. So congratulations on the CIHR award. This is just amazing and brilliant. And yeah, I just wish you all the success in it, and look forward to hearing about that in the next iteration of Research Week or Research Month. So being respectful, I know there's another session. I think it might be another, Camille, am I right that it's another Indigenous health based, some of the work that's happening in island health next, if people want to?
Yes, yeah, and the link is in the chat if they wanted to head on over, but if people want to stay to ask more questions, that's fine as well.
Just quickly, Kate, can you send that information about Carefit around?
Sure. What kind of information are you looking for in particular, Mike?
In terms of contact with Debbie and in terms of how that is going.
Absolutely. Yeah. we can pass on information how to reach us to Camille, and then she can distribute that. That'd be wonderful.
Thanks.
Cool.
Thank you.
Perfect. So if there are any last burning questions, I see some people are exiting, which they're allowed to do. And sorry, Jade and Debbie, for making you feel rushed if I made you feel rushed. But thank you so much for the presentation today. Okay, thanks guys. Day 2, 5 days in May, we're doing this. Keep it going. Bye everybody.
Thank you, everyone.
Yep.
Everybody.